think I've got a microphone, so I'm able to wander, I think, so which would be good. Good morning. I'm delighted to be the opening presenter at this conference and delighted to have been asked to do so. It is quite a daunting hall, so I can hopefully see some of you, but these lights prohibit me from seeing everybody at the same time. I chose this morning to walk around rather than standing at the podium, because this hall is so big. So I think if you're sitting over there, it's a bit hard to see what's happening over here. But also my flight arrived incredibly late this morning at about 1:30. I eventually got to the hotel at 2 a.m. And I couldn't sleep, so I think I've had about 1 hour's sleep since the 6 o'clock yesterday morning. So if I still stay standing for long enough, I think I might just fall asleep at the podium. So you're better off to have me walk around, and I'll continue to drink the copious amount of coffee that I think kept me awake in the first place while I was waiting for my delayed flight. The organisers asked me this morning to speak about a combination of person-centred practice, action research, and using research in practice. And hopefully I've tried to roll all of that into one presentation, and hopefully that might make sense to most of you in the room, and hopefully that might lead to a very high ranking on the evaluation sheet. What I want to talk about is to do a kind of a journey around what's going on in healthcare and in nursing and where we fit in that, and why, for me, person-centeredness is so important within all of that, and why it is that I think we need to change some of our lens in the way that we look at research and what research is actually about. In a little while, I'm going to define what I mean by person-centeredness, but I think for many of you in the room, you probably use the term person-centeredness interchangeably with patient-centeredness, or patient-centered care, or family-centered care. I come at that slightly differently, and if you just hold the idea of patient and person-centeredness being interchangeable at this point in time, until I get to the point where I'll maybe challenge that definition or that view that you have, then that will help us to get through the early part of this presentation. There's no doubt that currently in healthcare there are major agendas, and when we look at the international literature, not just in nursing literature but in healthcare literature generally, there are largely kind of four key agendas that seem to be occupying the minds of most strategists and policymakers currently. Firstly is the whole idea of patient safety, which has become a global industry and is one that is preoccupying most nursing planners, nurse leaders, and nurses in strategy in terms of ensuring that we have the highest, safest care possible for patients who use our services. Linked to that is the quality of the patient and family experience, and we've seen a significant shift happening around what we mean by the quality of experience, because for many years that has been very much about patient satisfaction, but over the last number of years the use of the word experience has changed that quite significantly, and we see much more creative methods being used to help to understand what does it really mean to experience healthcare, to experience nursing care, and how does that impact on me personally in terms of my own lived experience. Staff competence has been around in nursing in particular for a very long time, but I think more recently there has been a greater focus on staff well-being, and I'm interested in the Sigma Theta Tau and the Virginia Henderson Library that there's going to be a special open access issue on staff well-being, because it has become such an important issue in the way that we look at quality and safety and how it is that people perform, that if you're not well, if you're not keeping well, if we don't create a sense of wellness within our cultures, then how can we expect high quality care? And I'll be drawing on that a bit later. And last but by no means least, we have started to see a greater emphasis on what we're calling person-centered outcomes. So trying to evaluate healthcare and nursing practice from the position of the person rather than from how we as professionals or the organization or the system might actually view what it is that is going on. Now, I know those four big agendas might look differently in each one of our countries, all of whom are represented here today, but I think we could largely recognize that these are fairly common agendas across the healthcare systems globally today. But in the end, are our services any more responsive to persons as people? And in our work that we have done in 2012 with my colleague, Professor Tanya McCants, we have argued that, in fact, despite all of these movements, and despite all of this emphasis on person-centeredness, that what most patients experience in their care are what we call person-centered moments. That is, moments when they feel truly treated like a person, where they feel whole like a human being, where they feel that they are being cared for, where they're being loved, where they feel like they are a truly engaged person in what is happening to them, but that then there are long gaps in those experiences when they don't experience that, when they experience routinized care, where they're not communicated with, where they don't feel part of the system, where they don't feel that the care is really about them, and where they feel slightly disconnected and disengaged from what's going on. And we have described that as what we see in our healthcare systems and in nursing practice in particular is a dilemma between person-centered moments versus person-centered care. So we might espouse person-centered care, but in reality what we deliver are moments of person-centeredness. And our research we have summarized to say that there are largely about 7 reasons why this is the case, and I've listed those there, to do with consistency of care, to do with how care is coordinated, to do with the knowledge, skill and experience of staff, and a number of other factors. And I think, again, we probably all can recognize these factors as key issues that nurse researchers have been grappling with for many, many years. A personal communication with a renowned colleague of mine, somebody who is one of my heroes in life in the world of dementia care and an emeritus of my university, is Professor Fraser Gibson. And I had the sad duty, I would say, in 2010, 2011, to be her advocate, having when she had been a patient in a hospital. And it wasn't that she experienced what she described as poor care herself, but what she did observe was what she saw was very poor care in the acute system for older people who had got a dementia or an acute confusion. And her background is in dementia care. She's one of the leading ladies in dementia care. And she was horrified at some of the things she saw happen to older people who had got a confusion or a dementia within the acute care system. And whilst it was very easy to blame individual nurses, to blame individual doctors, to blame individual physiotherapists, or the whole array of other people who came in and out of her radar within that 2-week experience, for her it was a much greater issue than that. And the issue was that of a lack of a person-centered approach within the system as a whole. That the system itself was not helping those staff to do the best possible job that they could do. And in 2012, I had the honour and privilege of being part of an interesting commission that was launched in the UK by 3 organisations, which was the Commission on Dignity and Care for Older People. And this commission was set up in response to, which I'm sure many people in this audience have been reading about, the array of scandals that had been documented in the media in the UK about poor nursing, about patients dying from neglect in our hospitals, and a whole array of other issues that were essentially seen as the fact that older people in hospital were not being treated with dignity and respect. And so this commission was set up to investigate that in the same way that a royal commission will be set up to investigate any practice. And I chaired the academic reference group advising into the committee. And whilst I was sitting in on the evidence that was being provided, one of the really interesting comments came from a senior clinician who used this quote, which was this idea that the landscape and the system of care has changed so dramatically in the way that we organize ourselves that it's no longer possible for us to think about the way care is delivered in some kind of linear system where everything is carefully managed, but that the system is so complex and such a movable thing that it now is almost impossible for patients to know who exactly it is that is actually, for him, holding the parcel. If you think about the game Pass the Parcel, you need to know who's the next one in line in order to pass on the parcel to. And for this person, their view is that actually they didn't know that, and therefore the parcel sometimes dropped on the floor, and of course that meant poor patient care. And what that raises are issues about our team effectiveness, about the way we engage, and about how the system encourages us to actually work together. And research I'm going to be drawing on again later by Donna Brown and I argued that one of the reasons for this, one of the reasons why this kind of unsafe, poor care is allowed to happen is because many of our care settings are psychologically unsafe. That psychological safety is a huge issue within nursing practice and within healthcare teams generally, but that actually a lot of our settings aren't safe. And what we mean by that is that they aren't safe places for people to be able to speak up and talk about what is wrong and right within their practice. And Shine, who is one of the gurus around organizational culture and, more importantly, workplace culture, has argued that if we don't have a context where people are able to speak without a loss of integrity and without feeling too much anxiety, then we will never get the kind of quality care that we all espouse within our organizational missions and visions. And if we think about that in the context of staff wellness, then that becomes an important and very critical issue for us as nurse researchers and nurse leaders. And I do want to make a distinction between workplace culture and organizational culture, because whilst there's a huge literature about organizational culture, which is about the way an organization presents itself, about what are the key dominant factors that manifest itself in that culture, what are the things that make up that culture and describe it as a kind of a unique entity. What we do know is that more importantly for patients and staff is the idea of workplace culture, the culture that is experienced every day from people in a particular care setting. And I'm sure all of you in this room, in the particular organization you're working in, would be very able to recite the organizational mission, values, vision. You would? Yeah. And you could recite it, particularly if the CEO was coming in to see you, you would know exactly what the organization mission and vision are. The reality is, in most of our work, is that most people on the shop floor, so to speak, have no idea of the organizational mission, vision, or values. It's something that's often on the back of their name badges, but has very little resonance in how they are working on a day-to-day basis. But what they are able to describe very clearly is what their place of work looks like, feels like, and sounds like. What it means for them in terms of the values that are held, about how people engage and what that means for how we behave, and fundamentally what that means for patients. And a lot of our work currently is focused on collecting patient stories using narrative methods. And what is fascinating about that is that patients know very clearly what the values of a ward or a team or a setting is very, very quickly after very short engagements with staff by the way they behave, the way they talk, the things they privilege, and how they connect with each other. So this idea of workplace culture and the patterns that exist in it has a huge influence on the way the patients experience care and how staff engage with them. So our argument, therefore, is that what we need is a person-centered culture, that we should not just focus, or probably not focus exclusively, on patient-centered care and person-centered practice, but focus on how do we create person-centered cultures, cultures that enable that kind of psychological safety to take place and enable people to create the kind of practice that they actually want to create for themselves. And so because of that, we define person-centeredness in a slightly different way, I think, from most of the literature on patient-centered care. It is fairly true to say that there is no internationally agreed definition of person-centeredness, and I'm probably hoping we never do have one, because as soon as we do have one, then it will become another stick, and it will become another pillar that is unmovable. And whereas at the moment, person-centeredness is something that is more dynamic, that is creative, and is based on values, and something I think we need to hold on to. But what we suggest is that person-centeredness is about healthful relationships. And critical to this notion of person-centeredness is that it applies as much to staff as it does to patients and service users. The literature in patient-centered care in particular is absolutely dominated by the need for a person-centered approach to patients, and is fairly silent about what that means for staff. What rights do staff have in the context of being treated as a person just as much as patients have? And so our work is very much about saying you cannot expect patient-centered care or person-centered care, which we prefer to call it, if you do not have the same values and beliefs for staff. That is, that they have a person-centered culture where they are treated with respect, where they are treated like thinking, feeling adult human beings, where they are listened to and part of a decision-making system. Fundamentally, if we have a person-centered culture, we have what most interests me now in terms of my own research is a place where people flourish, a place where people feel a sense of growth, feel a sense of belonging, where they feel that they're able to stretch themselves and grow as people, and not just engage like automatons doing tasks, no matter how safe those tasks might be, but actually that they feel able to express themselves as a person and grow as a person and fundamentally flourish. The Irish psychologist Margaret Gaffney, if you ever get a chance to read this book, it's a good read, wrote a book in 2011 called Flourishing, so it's easy to remember. And it was interesting because it was published at a time when the Irish economy was at its worst. And here was a book to help us all to know how you should feel like being a better person. And it actually had that kind of effect, because what it said was, well, no matter how bad things might seem, then what we have to do is to always feel challenged. Not challenged in a negative sense, but to be challenged in the view that actually I am having to think about what I'm doing. I'm having to really not just do things in a routinized way, but to think it through and work it through and use all of my experience in order to come out with the best possible outcome. I also need to feel connected to other people. If I work in a team where actually I don't feel I really belong, where the team doesn't engage in effective communication, or they engage in what Marie Manthey described back in the 80s and 90s as the 4 Bs, the bickering, backbiting, and bullying. 3 Bs, I forgot there's another one. Bickering, backbiting, and bullying, then actually we don't have an effective team. We actually have a team that's quite dysfunctional and where it's disconnected. We have to feel a sense of our own autonomy, that I do have some sense of control over my own destiny, that I do have a right to make decisions even within a defined system, and that I have that right, and it's one that I'm able to exercise on a continuous basis. And again, I'll come back to that in the example I use. And the last one, which I find particularly useful in nursing context, a profession that has been dominated by competence, and particularly behavioral competence, she uses this idea of valued competencies, which I think is a much nicer way of describing expertise within nursing. Valued competencies are those life skills that we bring with us into our everyday work that make us the kind of human being that I am, that makes me be able to do this, that makes me actually feel that this is something that's important, and that I can bring all of my attitudes, beliefs, and behaviors together into that one moment of care. And it is these 4 elements that Gaffney argues make us up as a human being, and that if they're active, we're flourishing. If they're not, we're languishing. We're just existing through our daily practice. And I think it's an important point to reflect on, because in all of our different care settings, and as nurse leaders, then do we know how many of our staff are really flourishing? And how many of them are really languishing, going through the system day after day without having to really think too much about what it is that they're actually engaged in. Our most recent study, which was stretched across 5 different healthcare organizations, where over a 2-year period, as part of a large action research study, we collected patient stories continuously, and also staff stories we collected them about 3 monthly intervals over the 2 years to try and understand what it is that might help people to move from delivering person-centered moments to delivering a more person-centered care type service. And we found 3 particular things that stood out from everything else. The first thing is that of the mismatches that occur between the aspirations that people have for care and their actual experience of it. And this is both staff and patients. Patients have quite a diverse array of aspirations. Interestingly, no matter what, they all just expect to be safe. That goes as a given. So all the emphasis on patient safety kind of goes over the heads of patients, because they take that as a fundamental that they are going to be safe. And their aspirations are much more different than that, a whole variety of things. But what they often experience is that very quickly, their experience is very different from those aspirations. And those aspirations disappear very quickly. And sometimes they're lost and they can't quite get back hold of them. But the same thing often happens for staff, that their aspirations for how they want to work on a day-to-day basis disappear very quickly. And of course, we see that most prominently in newly graduated nurses, who, if they're not working in a culture that values them, that helps them to grow as people, then those ideals that they may have may just be that. They may just be ideals. There is also a key issue around the cohesiveness of the values held within the sociocultural environment. And what we found was that over the 2 years of this action research study, that when there was a much greater sense of shared values among team members, and particularly among multidisciplinary team members, then there was a greater chance of person-centered care on a continuous basis. Than when people were able to have an agreed set of values that drove their practice, when they were explicit, when they were talked about, when they were shared and discussed and challenged at team meetings, that they had a much better chance of actually being able to overcome some of the obstacles to delivering continuous person-centered care. And finally, we found what we have labeled the satisfaction dynamic to be significant. And I guess the take-home message is that measuring patient satisfaction is a bit of a waste of time, because what it really tells us are a set of predetermined criteria, largely developed through academics, of course done through a lot of focused group work and qualitative work in order to develop the right criteria, but we found very different stories going on underneath that satisfaction data. So we were looking at organizational satisfaction data and then looking at the stories that patients and staff told us about the real sense of satisfaction, and they were very different things. So there is a much more dynamic thing going on about satisfaction than what it is we might measure in some normative measure. So we have been working with a person-centered practice framework, and I'm not going to spend too much time on this other than to say that what it does is tries to help us to think through the movement from person-centered moments to person-centered care. The movement that tries to take account of these individual connections that we each might have and how they might come together into a whole care process. It works from the outside in, on the basis that there are prerequisites we have to have if we are going to be an effective practitioner. But no matter how effective those prerequisites might be, if the context isn't right for them, then we're not going to be able to use them to the best of our ability. And when we have those in place, then we operate in 5 key care processes, which are often referred to as the petals of the flower. And that engaging in those ways then delivers person-centered outcomes. And I'll just show those in a little bit more detail. The prerequisites, I just want to pick one in particular, which is that of knowing self. One of the things that comes out increasingly in our work is the importance of nurses and care workers knowing themselves. Who am I? Who am I as a nurse? Who am I working in this complex, unsettling environment? Who am I as a mother, a father, a partner, bringing all of that every day into my work? And how does that affect the way that I engage with people on a day-to-day basis? And we have started doing much more work on that in our undergraduate curriculum in order to help people to really think through who they are and what it is that they bring into each of the care situations that they're involved in. The care environment probably has got a lot of new literature happening at the moment because there's a huge emphasis on context, particularly around getting evidence into practice and this idea of the black box of context. But what we do know is that we need to have all of these things happening together if we are going to get effectiveness. And for example, if you take the last one, the physical environment, and look at the long-term care culture change movement in the US, it is largely focused on the physical environment. If you look at the Eden alternative and small home movement, what it has tried to do is to say if we fix the physical environment, then of course we will get other things to happen. But of course that is not the case, and the evidence is not quite there in terms of showing that that actually leads to more person-centered care. Because, of course, there's a much greater dynamic going on, which is a lot of these other things, and I'll come back to them. We would argue that no matter what care setting we work in, no matter how acute it is, or whether it's the community or whatever it is, that there are essentially 5 care processes that we engage in, and that if we engage in these on a continuous basis in a reflective way, then we are more likely to deliver person-centered care and experience a sense of well-being for ourselves as staff. And lastly, are the outcomes that we can measure and we can evaluate if we are trying to work in this kind of way. And again, importantly here is measuring the experience of good care from the perspective of staff and from service users. So, if we're to boil that down and say, well, what should a person-centered culture look like? Whoops, that slide was empty. Can I go back? You can have that. You'll have to read it on the I don't know, the text has disappeared for some reason. Person-centered culture should look like one that has got expressive leadership that is about facilitating people. It should have a culture that enables people to reflect on their practice and to be engaged in open dialogue about what it is that matters within their practice. It should have an emphasis on care, but care for both staff and for patients. It should have an emphasis on continuous learning and development, where that is a continuous part of what we are about and what we do as people. It should be a place where knowledge is an integral part of everything that we do. And fundamentally, it should be a place where we all can flourish. And so if we have those elements, then we can say that we're moving more towards a person-centered culture. And the text hasn't gone away this time, so I'm not that asleep that I wasn't able to remember it. So I would say to you, if you are saying that your service is person-centered, then you should be able to say these 5 things with some degree of confidence. Yes, we adopt a caring approach to how we meet needs. Yes, we nurture effective relationships. Yes, we do promote social belonging for everybody within this setting. We do create meaningful spaces and places, and we do promote human flourishing. And again, I would ask you as this conference goes on to think about how much of that actually exists within all of your care settings, and how do you get there if it's not quite where you think it should be at this point in time. So how do we make it real? There are many movements to try and help us to do it, and many agendas that I think are led in order to try and get things to feel more focused on people as persons rather than people delivering things and being effective in the organization. And going back to the idea of we can't just rely on more traditional methods of doing this, then draw on the work of the action researcher Stephen Kemmis, who argues that if we're thinking about an organization that is as fluid, is as complex, is as messy as the one that I'm just talking to you about, then we can't rely on traditional methods to change that. That is not going to come about by what is quite seen as simplistic change projects. It is a much more complex process than that, and requires a greater diversity of thinking about the way we do our research, development, and education. And drawing on the work that I referred to earlier by my colleague Donna Brown and I, which we did a few years ago, which was a large action research practice program to look at how could we get more effective pain management with older people in acute care settings. And we were particularly focused on surgical care settings at this point in time. The background behind this study is that Donna is a very experienced acute pain nurse, had set up an acute pain service in this particular hospital where I was then the co-director of nursing. And she came to see me one day saying, "I'm leaving, I'm out of here." And her reason was that she felt she had just had the same conversation with a group of nurses and doctors about post-operative pain management as she had had 18 years earlier. And in that time, of course, in that 18 years, she had done endless in-service training sessions. We had every protocol and policy possible. We had different pain algorithms for different pain groups. We had all kinds of work going on. We had acute pain management teams in place. And yet, she felt that 18 years of work was wasted because she still had had the same conversation with the same group of staff. So instead of her leaving, I convinced her to stay and do her PhD. And to actually step out of practice and to really look at this as a critical question for us to address as an organization. So we helped her to get out of practice for a year, first before she started her PhD, and asked her to do an ethnography, to say, go back into these settings and really look at them. Instead of looking at them through the lens of the acute pain nurse and your traumas of every day, trying to get these nurses to look and think differently and to get engaged with the medics, etc., just stand back from it and really study it using ethnography. And she did that for a year. And what we found was that this wasn't really about in-service or any of that, but there were 3 key things going on. Firstly, about how care was organized. It was poorly organized, not that continuous, etc. There were very poor coping strategies in place among staff, particularly among junior staff. So when they were busy or when they were being pushed, then all their knowledge about effective pain management disappeared. They resorted to kind of intuitive knowing that was ill-informed at times. And their pain assessment and practice, despite all the protocols, all the algorithms, wasn't happening. They were just asking people if they were a bit sore. And we used the Paris framework, which is a framework that I've been involved with for many years, to look at how we get research into practice, to think through what that might mean in terms of the culture within those teams, the leadership that was happening, and what that meant for how we could actually evaluate it. The issues that were going on within that unit, well, there were issues around the managers not working well together, so some of the things I said earlier, about how decisions that were made by one group of staff were abandoned or revoked by another group of staff. Was a lack of respect at all kinds of levels within the teams. There was what Bolton has called quietist navel-gazing, or what Marie Manthi did describe as the 3 Bs, which is where people went away to talk about their frustrations but actually never voiced them in public. And that all of that was having an impact on patient care, as in pain management was poor. So going back to our plan, we then, through Donna's PhD, set up an action research study. And Donna spent 2 years working in these, in 4 care settings, 4 large surgical wards, trying to help people to address some of these issues. And our intervention was essentially what we call an open space, a communicative space, where for 1 hour every week, an open space was created where the staff could come and reflect on what was going on with Donna and sometimes me facilitating them. And through those reflections and through those open spaces, then came a whole series of other actions through workshopping, changing different parts of practice, etc., over a 2-year period. And what we did while we were doing that was to say and to identify that actually this wasn't really about these 3 top-level issues, and it wasn't even about these 3 middle-level issues, the ones in green, which was communication, staff being interrupted, particularly when they were doing drug administration, and it wasn't even about the quality of pain assessment. But what the action research and these dialogues exposed was a much deeper thing going on within these cultures, a much deeper sense of what Shine has referred to as the embedded values within the team that was really having the effect on practice. So there were issues of power and how power was used and misused among different team members. And of course, like all nursing teams, they like to blame the doctors for taking away their power. But in reality, the disempowerment came from within nurses themselves. It was them who were creating disempowerment among each other. There was a loss of autonomy, particularly among more junior nurses. So a nurse who may have been graduated for a year was in charge of a team of patients today, but because tomorrow the nurse who was graduated for 2 years was on, then she was in charge and the autonomy was taken away. So that kind of hierarchical, ingrained thinking about seniority. There was a sense of oppression from a lot of people who felt that they didn't have a control over what they were doing, which linked to the idea of autonomy. The thing that probably influenced and interested me most was this idea of a lack of support, because as an organization, we had invested a lot of money in supporting staff through service development, professional development, etc., but yet they felt a lack of support as teams of staff. And central to it all was this sense of horizontal violence, which is in the feminist literature and is in the feminist nursing literature, which is this idea of not physical violence, but the continuous putting down of me as a person, this eroding of myself as a person by undermining me, by not listening to what I have to say, by not seeing what I have to say as being important, and it essentially erodes one's sense of self and is referred to as horizontal violence. And it exists among staff teams, and sadly exists hugely in nursing. And so what we did was to map that. We say, well, what's going on here? Because if this is really what's happening, what does it look like? And I'm just going to quickly flick through these because we mapped them against each one of the different concepts that we were looking at. And we were able to see that there were whole issues connecting with each other, and that fundamentally the practice settings look like this. And so my question to you is if that you are trying to develop a more person-centered culture, if you are trying to find a place where patients feel safe and where they experience good care, do you really think you can change that through a 2-day in-service, a half-day in-service, through a 1-day change program, through a particular change management on a particular thing that you're doing in practice? Because the reality is you won't. It will not happen in those kind of ways. It can only happen when we get inside this mess, or what we more nicely call the spaghetti soup of practice. So what did we change? Well, we changed a lot of things, as well as understanding, more importantly, what's going on in these kind of practice settings. So things to do with pain assessment, with leadership, with communication, with the way management happened, with the way interruptions were reduced, with the nursing team working more effectively with the medical team and become much more critical thinking. So a greater sense of these kind of practices. We were able to demonstrate through outcomes, because we were measuring pain assessment through hard measures through all of this program, as well as measuring pain assessment outcomes for patients post-operatively as well. And we were able to demonstrate that this 1-hour intervention each week of a space where people could talk actually had a significant impact on both staff experience and on patient outcome post-operatively in terms of their pain management. So to conclude, what this leads me to argue is that if we are going to really be serious about having person-centered cultures, patient-centered care, places where people feel they belong and can grow and can flourish as human beings, then we have to not do what we've always done before. We have to think differently, and particularly us as researchers have got to think differently about what it is we're doing in our research when we're taking on some of these agendas. And I'm very influenced by the work of Michael Gibbons and his idea about mode 2 thinking in knowledge. And Gibbons is a great reformist and was particularly active post-apartheid in South Africa in restructuring the university system to make it much more inclusive of communities across South Africa. And what Gibbons argues is that traditional research as we know it, which is largely we as the knowledge producers, produce the knowledge largely in universities and then hand it over to the knowledge users who are largely in practice and say, here you go and use it. And we do some implementation things and they don't work and we think we have to do another research study. That's mode 1 thinking, that it doesn't actually lead to a different kind of engagement. Whereas mode 2 thinking is that we have to exchange knowledge from the outset with people. We have to be with people, with those people who are wanting to use knowledge a different way. We have to be alongside them, be with them on a continuous basis from the outside. We have to create conditions where people can translate this knowledge, where they can work their way through that spaghetti soup of practice, because that is the day-to-day reality. No matter how nice we think our setting is, that is the day-to-day reality for most of us in a practice setting. And fundamentally, what we're trying to get to is a position of co-production, where we're all working together to produce that knowledge. So it's not about the knowledge producers and the knowledge users, but it is all about co-producing and co-using the knowledge that we're generating. So what does that raise for us as some issues? Well, I think firstly, it asks us to reflect on our own research and what is the purpose that we're trying to achieve. What is it we're actually trying to do? If we have an intent of changing practice, then do we stick with something that is in mode 1 thinking, or do we need to shift our thinking in terms of the kind of research that we're doing? And shifting our thinking does not require a shift in rigor, usually downwards, because people who hear this always say that means less rigorous research. What it means is more messy research, but that doesn't mean less rigor. Co-production does have emancipatory and transformational intent, no doubt. If we are going to change that spaghetti soup of practice, then that requires a lot of transformational work. And my question to all of our organizations are they ready for that? My experience is that they are largely ready until it really gets hard, and then they want to step away from it. So we have to do a lot of work with leaders, managers, directors, executives, with ourselves as staff teams to really understand what it means to transform the practice that we're actually wanting to do. Research is dominated by powerful paradigms, and we won't rehearse some of those old wars, but we have to really think through those paradigms if we are going to be serious about having cultures that are truly respectful of persons. We need to think about what impact really means. Is impact really about journal impact factors? Is it really about getting into the highest rated journal? Is it really about my publication rate? Or is it really about that really subtle effect that I might have on a particular care outcome and a particular group of staff, which of course largely serves for nothing within most of our university systems? And we need to broaden our methodological lens. And if we are doing that, then what does that mean for research training? What does it mean for the current cohort of doctoral students who aren't being trained in co-production? They aren't being trained in how to really engage in knowledge exchange programs, but they are being trained as researchers, and within that, thinking about knowledge exchange and co-production. So as a research community, and a very large research community here, if we are being serious about creating a person-centered culture, and I'm guessing, because I was put on as the first keynote, that we are trying to be serious about it, then I think we should reflect on these over the next week at this conference and beyond, and really think about where do we want to be if we are going to change the kind of practices that we know to be important to change. Because what we have to do is actually not try and shy away from the fact that now our care settings are highly political, they are highly challenging, they are highly stressful, and they are always going to be so. And how is it within those settings that we can help people to feel more human and to feel more person? Thank you.